Happy Sunday. So, there's a patient you won't forget, not because of how dramatic the wound was, but how quietly it refused to heal. I think that's quite common. A diabetic ulcer. Nothing unusual at first glance. No overwhelming infection, no obvious ischemia screaming at you, no catastrophic trauma, but the wound just sits there stagnant, dry, stubborn. You change the dressing, you optimize the offloading, you debride appropriately, you send cultures, you check perfusion, and you even consider imaging, and still nothing changes. At some point, the question becomes uncomfortable. What am I missing? That's something you should always ask yourself because everything looks fine. You feel like you did everything right. And the wound looks like it never got the message to start healing. Then, almost as an afterthought, you notice something. You notice that the patient's lips are dry, that the patient's skin turgor is poor, that their urine output is low. Labs suggest hemo concentration. They admit almost casually, I don't drink much water. It makes me go to the bathroom too often. That is something common that patients do say, unfortunately. And suddenly the story shifts because what looks like a stubborn wound is actually a system that is slowly drying out from the inside. And this Diabetic Foot Files episode, today we're going to talk about dehydration, not as a symptom, but as a silent driver of limb failure. One of the most overlooked threats in wound healing is an infection, isn't just poor circulation, but it isn't just high blood sugar, but it could be dehydration, especially during the summertime, especially with, the ecosystem right now and the sun. A lot of people are dehydrated. Many patients with diabetic foot ulcers are chronically dehydrated and don't realize it. Every cell in our body, every cell in wound healing depends on water. Without adequate hydration, healing slows down at every stage. So, what does hydration really mean in wound healing? So, hydration, most people, when they think hydration, they think comfort, they think thirst, they think water bottles, they think summer heat. But in wound care, hydration is not comfort, it's a physiology. Water is an infrastructure for healing. And without water, oxygen transport becomes inefficient, nutrients don't reach the wound bed effectively, cellular migration slows down, waste clearance becomes impaired, tissue oxygen tension drops. And let's make it simple. If the blood is a highway, right? Like I like to use blood as a highway a lot of times when I explain to patients. The water is what keeps the traffic moving slowly. Now, imagine that highway inside the diabetic patient already narrowed and already decreased and already compromised by microvascular damage. Now, remove hydration from that system, and what happens? The traffic slows down, slow down, that it starts crawling, right? The wound becomes the first place you see that collapse because the wound are metabolically expensive. Wounds are metabolically expensive. They require constant delivery, constant clearance, constant cell turnover. They, no hydration, no flow means no repair. And because of that, that's why water is so important for our wound healing. As everybody knows, your body is approximately, they say about 70% water, right? Our body. 50 to 70, I believe it's 70. That's what they teach us. 70% water or 75. A wound is essentially a construction site. To repair damaged tissue, the body needs to deliver oxygen, deliver nutrients, remove waste products, transport immune cells, build new blood vessels, produce collagen, maintain healthy skin elasticity. And all of these processes depend on fluid movement. So think of blood as a delivery truck. And when you're dehydrated, the blood becomes more concentration. And we did a whole episode on hemoconcentration. And when the blood becomes more concentrated, it's less efficient at trapping the transport supplies to the wound. So let's look at what dehydration does to a wound at a microscopic level. So at a microscopic level, dehydration pretty much changes everything. I'm pretty sure been dehydrated. I have, especially during this hot summer. So blood viscosity increases. I mean, you already know that diabetic patients, their blood viscosity is already quite thick because of the hyperglycemia, but blood viscosity increases as well with dehydration. So when the plasma volume drops, your blood becomes thicker, your capillary perfusion slows down, red blood cells move less efficiently. And in diabetes, where these capillaries are already damaged, this becomes quite critical. So the smallest vessels fail first, of course, and then the wound bed becomes full of them. And the the blood volume decreases, and the body responds by preserving the blood flow to the critical organs that they care about the most, which is the brain, the heart, and the lungs. So your feet are not prioritized when it comes to dehydration. And for our diabetic patients who already have peripheral arterial disease, microvascular disease, neuropathy, even mild dehydration can further reduce tissue perfusion. Now, another thing that happens with dehydration, your oxygen delivery drops. Remember, oxygen is our healing currency, and oxygen is not just carried, it is delivered. And delivery depends on what? Blood flow, right? And the slower flow means more hypoxic tissue, slower fibroblast activity, and reduced collagen synthesis. Another thing that happens with dehydration is cellular migration stalls and collagen production fails. And collagen is a scaffold that helps close wounds, right? And the main protein responsible are we have our fibroblasts, we have our keratinocytes, we have our macrophages, and they all need a nice hydrated extracellular matrix to move. And fibroblasts, right? We love our fibroblasts. Proliferative phase, fibroblasts, collagen, just those three words, right? Fibroblasts requires a healthy, hydrated environment to function optimally. And dehydration creates this cellular stress on the body and the entire body that can reduce the collagen deposition. And without it, the wound bed becomes sticky. It migration slows down and reepithelialization halts. Now, another thing that happens with dehydration is the womb bed becomes biologically inactive. It's like hitting the pause button. And this is what we describe as what we say in quotation marks a stalled wound, a non healing ulcer, a dry face. But biologically, what it really means is that the environment for the wound's environment, no longer is supporting life effectively, okay? Another thing that happens with dehydration, the skin becomes fragile. Diabetic skin is already quite fragile, but dehydrated skin, you're going to crack easier, the tears are going to be easier, you'll develop fissuring easier and lose elasticity. For a diabetic foot also, we have the increased risk of callus formation, skin breakdown, and new ulcer formation. Another thing that accompanies dehydration is increased inflammation. Dehydration can increase circulating stress hormones and inflammatory signals. So, chronic inflammation is already a major reason why diabetic wounds become stuck in the inflammatory state. So, adding dehydration to that, you're just worsening the outcome, okay? So why are diabetic patients at risk? Okay. So now let's layer diabetes into the whole entire system, and everything gets pretty much amplified. We have osmotic diuresis. So high blood sugar, high glucose levels pull water out of the body. So the patient is losing fluid through urine and and pretty much without realizing. Next, reduce thirst response. Many patients, especially older patients, don't feel thirsty appropriately enough, so they don't replace what they lose. Next is intentional fluid retention. Some patients avoid, like what I hear sometimes, avoid drinking water because they don't want to urinate frequently, right? They have a fear incontinence and they'll think that it doesn't matter. And sometimes you gotta think about yourself when it comes to dehydration because you'll realize, "Oh, I only urinated twice today." That's not normal, okay? That's not fully normal. Or, "Oh, I only urinated once a day." Yeah, you're most likely very dehydrated. Another thing is we have to think about the morbidity medications that a lot of our patients are on, like diuretics, antihypertensive drugs, and other drugs that can compound fluid loss. So, what do you get? A patient that looked clinically fine but slowing down their healing because dehydration has become their baseline, and the wound becomes the first sign of a visible failure point in this dehydration pattern. Okay. So, what are some of the clinical signs that we could miss? This is where experience matters. So dehydration doesn't always announce itself. It just a lot of the things when it comes to wounds. One thing I love about wounds, wounds don't lie. Okay? You just have to figure out what they're trying to tell us. But wound clues that they might be dehydrated, dry, shiny, leathery wound bed, minimal exudate in a case that where the wound should be wet, slow granulation despite good care, hyperkeratotic edges, poor response to advanced dressing. Systemically, clues would be dry mucous membranes, tachycardia, orthostatic symptoms, fatigue, and confusion in elderly. Now, our lab values elevated BUN or creatinine ratio. So, our BUN, which stands for blood urine urea nitrogen, blood urea nitrogen, BUN. The normal value is 7 to 20 mg per dl. Elevated BUN may indicate dehydration and reduced kidney perfusion. That's often indicator. Another one is the ratio, right? So normal ratio is 10 to 1 or to 20 to 1. When the ratio rises above 20 to 1, dehydration becomes more likely. So example, let's say the BUN is 40 and the creatine is 1, then the ratio is 40 to 1. That is a strong suspicion of dehydration. Next is our sodium levels. So our normal sodium levels, that's something I can always remember, 135 to 145, right? MEQ per L. So when water loss exceeds sodium loss, sodium levels do rise. So elevated sodium may suggest dehydration as well. May, okay? That's a good reason why you should know all your labs. May does not confirm, okay? Next is your hematocrit levels. So men and women do vary when it comes to hematocrit levels. Men are 41 to 53%, and women are 36 to 46%. And when the plasma volume decreases, the blood becomes more concentrated and the hematocrit rises. So also, you have to also remember hemoglobin may appear falsely elevated due to the hemo concentration. Isn't like the patient does not have more red blood cells, it means that they have less plasma. Next, another useful thing to see our hydration of our patient is the urine specific gravity. Normal is about 1.005 to 1.030. Higher values suggest concentrated urine, and common dehydration values are like 1.025 or above 1.030. Okay. Or like, like showing a mild electrolyte imbalance. Another is urine osmolality. And as dehydration worsens, your urine becomes more concentration. So a urine osmolality, okay, forgive me, increases. So another one is serum osmolality. So normal serum osmolality, I know I'm not pronouncing that so well. I want that to roll off my tongue so much better than that. Approximately is 275 to 295 MOSM per kilogram. Elevated levels may indicate dehydration. But what is the most important clue? One of the most important clues is that everything pretty much is optimized, but nothing changes. Okay, so think systemically. Don't just treat the foot. Treat the patient. The patient is a whole. Okay, the body is one. Okay. So why does dehydration get misdiagnosed? Dehydration is often missed because, yeah, it is quite simple to miss, okay? We're trained to look for complex causes like PAD, infection, osteomyelitis, biofilm. Rarely do we hear look for water imbalance, right? Besides when we see maceration, right? Next is dehydration is quite quiet, okay? It does not present as an emergency. It slows everything down. You know what's happening also in the schools? The young kids are getting dehydrated because of how hot the sun is, and kids, they don't really think about drinking water as frequently as they should. But everybody, especially in this hot summertime, you need to drink enough water. So always remember that. Now, Okay, now we all know there is something called water poisoning. So I'm always telling people, do not go overboard. Nobody's asking you to do that. Balance, balance. But you need to keep hydrated, especially in all this heat. What do you think is keeping you alive while it's so hot and you're sweating? You're sweating fluid, water, okay? Even some people, when they get sweat so much, they get crystals on their body because it's like sodium, right? So think about all that. And then dehydration can be masked by other diagnoses. So in our diabetic foot care world, everything is crowded. There's neuropathy, there's ischemia, there's pressure, there's infection. Dehydration gets lost in the noise of that, okay? And but sometimes dehydration is the noise. So what happens when we fix it, okay? When you correct dehydration, blood flow improves, of course. And you gotta here's another thing. It's personally affected one of my family relatives, CHF, congestive heart failure. The fluid and drinking water is kind of difficult for them because they kind of feel like they're drowning. I One of my family relatives I love so dearly, he was afraid to drink water, unfortunately, because of how congested his heart was and the fluid retention and everything. It was a scary time. So, you got to speak to your internal medicine doctor about all of this because you have to remember when the patients are on diuretics, they are losing a lot of fluid because they're having a lot of fluid retention. Their heart's either managed, they have less swelling in their legs and body. Like all these diagnoses are sometimes, it really is a lot. And it's amazing that the human body can endure so much. And, I think any patient that has a diagnosis, y'all are some amazing warriors. Y'all power through it. Y'all try to do what you have to do. And I just want patients not to be forgotten by the healthcare system. I want everybody to get a full good evaluation, be treated overall and not be misdiagnosed. I saw something about a woman who I guess her family sued because I believe she had congestive heart failure. I think she was a Star Trek or Star Wars woman, but she already passed away. But they didn't treat her properly. They didn't treat her medical diagnosis properly, and I think she had congestive heart failure, and they didn't treat her properly, and she ended up dying, unfortunately. And it's a story that's way too common. Seeing this, that people are getting not just misdiagnosed, they know what's wrong, but they're not getting the optimized treatment that they need to fully be have their symptoms resolved or be efficiently alive. And I just don't like that because human life is such a beautiful thing. I mean, like Mother's Day just passed. Everybody had a mother, no matter if they have the mother in their life or not. It took 9 months for this person's body to form in such a beautiful manner that we created this beautiful life. And to discard that beautiful life just because, I guess, overwhelmed, overcrowded, lack of empathy. I just don't like there is epidemic that's going on right now with the lack of empathy in healthcare. Care, care. This is not about you. This is a people business. This is a healing business. We're supposed to save lives. I'm confused about what's going on. Like, I would expect every single person that works in the healthcare field, their goal when they wake up is, yes, I need to save a life. I need to make the quality of care of my patient's life better. I do not want to hear nobody saying, "Oh, when is lunch?" Okay? What are you talking about? What do you mean? Like, if you kill a patient, if you misdiagnose a patient, if you don't listen to a patient, they might not have a lunch the next day because you misdiagnosed it. People need to carry accountability. Okay? That's the whole point of certain audits because you're going to be like, why did this patient get misdiagnosed and almost at the brink of their life? I even had a friend, I'm catching up on it. I'm so happy they got engaged. I'm so excited for them. But her father almost passed away because they misdiagnosed him in a hospital. They said he did not qualify for imaging. Here, that was stupidity and scraps of humanity at its best, okay? Saying the man did not qualify for imaging. The man was septic. They didn't know what was causing the septic. You would think that they would get the right imaging, right? They said he didn't qualify for any imaging. So, of course, his children would, thank God that they had the resources. They took him out of the hospital, flew him to a different country. They did the imaging home. He had a liver abscess. So, what type of hospital is this? And this is in the home country. What type of hospital is this where people say you don't qualify for imaging, but they're septic and they end up finding that the person had a liver abscess? Thank God that he got better. But I'm like, wow, I'm not surprised because there are scraps of empathy, scraps of humanity, scraps of caring about the patient. Why isn't anybody saying anything? Why isn't anybody fixing anything? I'm not there to fix it anymore, but I'm like, why do you think this is okay to treat your native people like this? What? Who is not? Why is the person who's in charge of this not speaking up, saying this is deplorable? You should not be treating people like that. I'm on a whole different tangent, but things like this get me really annoyed. And like I keep on saying, if you're in charge of that area of healthcare, right? Only you and your family only need to go there so you can see how it feels because people only learn through pain and God. And if you say you're a Christian and you're allowing stuff like that to happen, you're not a Christian. You don't believe in God because God is the God of life. Okay? So if you're saying you believe in God and you're letting things like this happen, no, not a Christian. That's not what God wants you to do. Absolutely not. There's no doubt in my mind that that's not what God wants you to do. He wants you to just discard patients and let them die. And when you see there's an actual problem in a part of the healthcare system that you're not going to address where you're in charge of it, yeah, you're not you're Christian, so you either have to learn through pain. And you know what? Life will bring pain that you create, okay? So if it happens to that person, nothing I can do about it, because if you're in charge of it, God gave you the opportunity to make a change positively, and you're not changing it and you're just sitting around eating, drinking, and on top of that, if you're a doctor and you're in charge of the healthcare administration or whatever, and there's lack of healthcare providers, whatever, you can volunteer too. If you got that DR in front of your name and there's lack of healthcare providers or doctors, you can volunteer your time, like maybe 5 days a week. The government's already paying you. Let's see how you keep up with those CMEs and keep up with that knowledge. I bet you didn't. That's what I believe because I would never think anybody who knows their stuff would allow any of this to happen. It doesn't make sense. It doesn't make sense. You need to be better. And I'm just kind of disgusted by how the healthcare system in the home country is because people are complaining. And it's not about complaining. You deserve to live. You deserve healthcare. And then on top of that, one thing they're not gonna miss, billing the patient. The patient saying, "Oh, I got a $20,000 bill." "You got a 20,000 what? And you're still sick?" No. On top of that, the people misdiagnosed, and then on top of that, what usually happens is the people who do have the money, they are able to have the resources to move their family relative to another hospital outside the country where they're getting better healthcare, and the people have the audacity to bill them at the home country. It's disgusting. It's absolutely disgusting. Okay, so let me that was a whole side tangent, forgive me. But let me go back. So when we create correct dehydration, blood flow improves, perfusion stabilizes, wound beds become more active, exudate normalizes, and granulation tissue returns. It could look like a miracle turnaround, but it's not a miracle. Like I said, it's not a miracle, it's a marathon, and it's pretty much physiology restarting. So, how much water should we drink during the summer? Okay, not one size fits all. Speak to your internal medicine doctor and your nutritionist about all of this because they have all the labs and know what you need and they know all your comorbidities. But it all depends on your body size, your activity level, the temperature, medications, as well as kidney function and heart function. Okay, but they said for the average female, about 2.7 liters total fluids a day, so about 1 ounce, and for male 3.7 liters, okay? About 125 ounces a day, okay? But talk to your internal medicine about that, okay? Because during hot summer conditions, sweating significantly increases your requirements, especially like running around and things like that. And for our wound care patients who are outdoors exercising and you're just working, fluid needs to be rise substantially to help. Okay, so simple hydration goals often is clinically you see it through your urine. Your urine should be a nice pale yellow. If your urine is a dark yellow, I know that some vitamins cause your urine to become dark yellow or green, but a dark yellow usually indicates inadequate hydration, okay? So clinical interventions would be oral hydration protocols, IV fluids. Sometimes they emit them if they're really dehydrated. Electrical electrolyte correction, glucose optimization, and medication review. Okay, because sometimes your medications are really causing you more dehydration and more harm than good. So your doctor has to go through it with you. Do not ever self-medicate or self-diagnose or make all your medical decisions on your own. Make an educated one with your physician. Okay, and A special warning for our diabetic patients, high blood sugar does create a problem. The glucose, the hyperglycemia, the kidneys do attempt to remove the excess glucose through the urine. So you're going to have increased urination. There is increased water loss with the urination and electrolyte loss. So many of our diabetic patients become dehydrated simply because the glucose levels remain elevated. So keep that in mind. Keeping your blood glucose levels, your hyperglycemic levels, your glucose levels at good norm is helpful when it comes to dehydration as well. Okay. And we do lose water from our wounds, okay? Sometimes even as clinicians, we forget that wounds themselves lose fluid. Heavy drainage usually results in protein loss, electrolyte loss, and fluid loss. Large wounds, heavy exudative wounds may contribute significantly to dehydration, especially in our older patients. So practical hydration tips for our patients: drink consistently throughout the day. Water, I'm not talking alcohol, absolutely not. Increase your fluid intake, especially during hot days. Speak to your internal medicine about this. Monitor your urine color. Monitor your blood sugars closely. Replace fluids lost through, especially if you're sweating excessively. Discuss fluid goals with your physician, especially if you have heart failure, kidney disease, or if you're on dialysis. A lot of our diabetic patients are on dialysis, or if you have severe edema, these conditions do require fluid restriction. So keep that in mind, okay? So the takeaway is a diabetic foot ulcer is not just a local injury, it's a reflection of a systemic balance in your body. And dehydration is actually one of the most overlooked disruptors of this balance. Affects perfusion, immunity, cellular migration, tissue oxygenation, as well as healing velocity. And remember that patient from the beginning, that one with the stubborn wound, that one that everyone thought needed a new dressing, a stronger antibiotic, or a different approach. What they really needed was a restoration of their basic physiology requirement, which is water, water balance. Okay, and sometimes healing doesn't start with something advanced. Sometimes it usually is the simple answer. Okay, a simple answer that was overlooked. Okay, and a hydrated wound healing patient is giving their body this one of the simplest, as well as least expensive, as well as most biologically important tools for recovery. Remember, dry wounds do struggle to heal, but a dry patient struggles even more. In diabetic foot care, we often chase their dramatic symptoms, right? Infection, ischemia, surgical urgency, but sometimes the most powerful intervention is not dramatic at all, it's foundational. Hydration is not just supportive care, it's a healing infrastructure, and when that system dies out, the wound follows. So this is Diabetic Foot Files, where you never ignore the basics. I'm Dr. G. I hope everybody has a great Sunday and take care of your feet because they take care of you.